morning, everyone. My name is Bita Esmaeli. I am an oncologic ophthalmic plastic surgeon, and I'm going to talk to you about surgical treatment of malignant eyelid tumors. As I mentioned today, first of all, I have no relevant financial disclosures. We're going to have an overview of each of the malignant tumors of the eyelid. And I would like to specifically cover surgical treatments for eyelid tumors, and also we'll touch upon some of the newer non-surgical treatment options that may or may not be available in various different parts of the world, but it's still good to be aware of their availability just in case. So we'll start with the most common cancers that happen on the eyelid and periocular region. Basal cell cancer is the most common cancer in humans, period. In terms of sheer numbers, this is the most frequently encountered cancer in humans. I believe that we can say throughout the world, but of course, a little more frequently encountered in Western and Northern hemispheres because of sensitivity of the skin type. It's estimated in the US that there are 3.5 million cases of BCC each year that are diagnosed, and they're about 80% of all cases of non-melanoma skin cancer. And about 15% of all basal cell cancers occur in the periocular and eyelid area. So in terms of frequency, it's a significant number of cases. And most often they happen in the lower eyelid, but they can also occur in the medial canthus, in the upper eyelid, and in the lateral canthus in less frequency. So a typical case may be, as shown in this photo, we talk about typical features of basal cell cancer, usually a slow-growing lesion that has pearly gray borders. It has some telangiectasia. It's associated with loss of lashes and destruction of soft tissue. So this is, no doubt it's a cancer, it's a skin cancer, but probably a basal cell cancer based on this appearance. And of course, usually a biopsy is done, and there are histologic features of basal cell that are typical, peripheral palisading, mitotic figures, the cleft. But the treatment, since this is a talk on surgery, the treatment is surgical resection with frozen section control of the margins. In many countries, this is done via Mohs surgery, which is essentially paying attention to the margins of resection using frozen section. If Mohs is not available, any method of frozen section evaluation of the margins would also be appropriate. And once the margins are clear and there's no histologic or microscopic cancer remaining, then the defect is closed and repaired using the usual techniques. In this schematic, we're showing how we close a relatively small defect of the lower eyelid. These are essentially repaired in layered fashion. First, the tarsal plate, which is the dense collagenous structure in the inner part of the eyelid. First, we close that, usually with vicryl sutures, and then the lid margin that is closed with silk sutures with some degree of eversion, because over time this will settle and we want to try to avoid notching. So it's better to use either mattress sutures as is shown here at the lid margin, and also in these real life examples. This is a defect, small defect, closed primarily. And this is the immediate post-op. You may get some inflammation associated with the sutures, but really it should resolve over time with very nice appearance and outcome. And then moving on to, let's say, this medial canthal basal cell cancer. This is a more of a infiltrating basal cell cancer. It's recurrent. And you can see that by the time we clear the margins, there's a very large defect. So these are still handled surgically. Again, whether you use the wide excision with frozen section control of margins or essentially Mohs surgery, the idea is not to leave behind any microscopic cancer before doing the repair. In the medial canthal area, a very nice option for repair is what we call a glabellar flap. This is a flap. It's a random flap in the sense that it does not have a blood vessel that is dissected with it. And it basically is recruited from the glabellar area. Here you can see that the area is marked, and then it's rotated into the defect. It can cover even very large defects and does really well in the medial canthal area. So these are examples of large basal cell cancers. This one on the right is a recurrent case with some secondary pigmentation causing some cicatricial ectropion. For some of these larger lesions, now we do have some drugs that are available. They're available in many countries in the world. At least 70 countries have these drugs approved and under formularies. They're referred to as sonic hedgehog inhibitors. And there are two drugs in this class, vismodegib and sonidegib. These are oral medications that can be taken for very large basal cell cancers, as is the case in this patient. You see in the photo on the left. After taking vismodegib, which is a sonic hedgehog inhibitor, after a few months, he has resolution of this large ulcerated lesion. Of course, these drugs are not necessarily curative, but they are targeting downstream proteins from the patch gene. So it is important to note that they're only appropriate for shrinking the tumor, but they should be combined with surgery for greatest success. But of course, not for the entire lesion, but hopefully for targeted areas to sample, and only in patients who are reliable for follow-up, because otherwise we may encounter cases of late recurrence that go unnoticed. They're also good for cases of Gorlin syndrome or basal cell nevus syndrome. This is an example of a basal cell nevus syndrome. This patient has numerous basal cell cancers on his face. This condition is also, it's autosomal dominant, and it is also associated with what we call palmar pits. These are tiny little pits that you can see in the palm of the hand, these tiny little pits, and odontogenic cysts. This is a condition that, of course, we used to treat it surgically, but now with the availability of sonic hedgehog inhibitors, we do have that option to offer. You can see this patient has had nice resolution of all of his lesions. And of course, the asymptomatic small basal cell cancers in patients with Gorlin syndrome can be simply observed. They don't need to be tackled with surgery or medication. So moving to other cancers that happen in the periocular region, squamous cell carcinoma is the second most common lesion in the Western hemispheres and in the United States, certainly. In some parts of the world, this may be the most common cancer seen. And it's a bit more aggressive than basal cell cancer. You can see a little more tissue destruction in a more rapid fashion. And it is still most often seen in the lower eyelid, but we may have a slightly higher proportion of them occurring in the upper eyelid as well compared to basal cell cancer. The risk factors are ultraviolet exposure, HIV, HPV, as well as immune suppression, including a history of organ transplantation. And you can see various different sizes and spectrum of clinical presentation. Here's an example of a real subtle squamous cell carcinoma in situ, meaning in the earliest possible stage. And all you can see here is a bit of inflammation and loss of eyelashes. So we do need to have a high index of suspicion, especially if we have just a very focal area of inflammation at the lid margin. And this is the histologic corresponding slide to this lesion. You can see that the squamous cell carcinoma and atypical cells are just limited to the epithelial layer, and there's no invasive component. So for larger lesions or for any lesion that requires surgery, we still do similar to basal cell cancer. We do surgical excision with frozen section control of the margins. Most surgery can be effective for squamous cell carcinoma, but of course, with slightly larger margins, just because this is a more aggressive cancer than than basal cell. Even with this very large or ulcerated lesion, this patient was able to retain the eye and have a fairly nice outcome of reconstruction after a tarsoconjunctival Hughes flap. And this may be a good opportunity to now talk about larger defects and how we repair them. This is a schematic of a semicircular Tenzel flap. This is named after Dr. Tenzel, where in addition to the primary closure at the lid margin, we recruit some of the laxity in the lateral canthal area. You can see this semicircular flap that is based in the lateral canthus. The remaining island of eyelid can be moved medially and repaired to this area. And then the lateral defect is closed by recruiting the soft tissue from the lateral canthus. The inside posterior lamellar defect can be either repaired with conjunctiva, that is just simply dissected and moved upwards, but more reliably, it should be repaired with probably periosteal flaps that are just very handy right here in the lateral canthus, on the bone of the lateral canthus. We can harvest the periosteal flap and just swing it medially and use at the posterior lamellar replacement for the lateral defect. Here's the example real life. You can see the recruitment of the lateral canthal soft tissue and a nice outcome. A slightly larger defect, let's say 2/3 of the lower eyelid, involving the tarsus as well. These are best really handled with the tarsoconjunctival Hughes flap. As again, you can see this in the schematic, and I'm going to show real life examples, but just to understand the steps involved, the upper eyelid is everted usually over a Desmarres retractor. We leave about 3 to 4 millimeters of normal tarsus in the upper eyelid margin, and then harvest the rest of the tarsus and swing it down into the lower eyelid defect. This is the tarsoconjunctival flap in place. It remains attached to the upper eyelid, to its upper eyelid source for blood supply. And then it's sutured to the surrounding remaining tarsus, and inferiorly, it's sutured to the conjunctiva. Vicryl sutures are used. This is a sagittal view. You can see again, this is the flap sutured to the conjunctiva inferiorly. And then on its anterior surface, most often we can use a small skin graft from the upper eyelid, harvested from the upper eyelid or other sources. Or you can just simply, if there is redundant skin in the lower cheek area, you can just undermine it and bring it up and suture it here. So this is a very, very handy flap. But important to note, it's a two-stage operation because this source of blood supply needs to remain attached to the upper eyelid for several weeks, and also to provide stability for the position of the lower eyelid. It's not just about the blood supply, but it's also about the position of the lower eyelid that is more stable when it's attached to that upward traction for several weeks. So here's some real life examples. Again, this is the 4 millimeters of tarsus in the upper eyelid left behind. Here's the flap. This is the nice, sorry, let me go back. This is the nice flap here, healthy flap, rotated downwards into the defect, sutured to the remaining islands of tarsus, and then covered by a skin graft. Here's an example of a squamous cell carcinoma that occurred in the tarsal plate. You can see the area of biopsy. And just to show the power of tarsoconjunctival Hughes flap, this is what the defect looked like by the time the margins were clear. You can see the exposure of the inferior oblique muscle. Of course, we leave it alone and preserve that muscle. But here you can see the tarsoconjunctival flap in place. It's been sutured to the remaining edge of conjunctiva. There's not much of it left, but that edge that's remaining, it's sutured to that. And you can see the pedicle of the flap is really made of conjunctiva that's attached to the upper eyelid, and very few fibers of Mueller's muscle that are remaining. And then a skin graft is taken from the upper eyelid. Here's the incision for the harvest of the skin graft. and then sutured on the anterior surface of the tarsoconjunctival flap. So really, if you do this a few times, you will see that it's a really reliable, very handy flap for larger defects of the lower eyelid. And here's this patient in the in-between stage. As I mentioned, the flap needs to remain attached to the upper eyelid for several weeks. In this in-between stage, the patient looks like this. The eye is closed. So as a note, this may not be appropriate in children in this type of flap because in patients who are in the amblyopic age group, we may want to avoid an eyelid sharing flap like this. But in adults, it's very helpful and it's very useful. So for several weeks, the patient may just mostly rely on the opposite eye. And then, so it would also be a problem in a monocular patient. If this happens to be the only seeing eye, then we may need to use other methods of reconstruction. And in this particular patient, she was also receiving postoperative radiation therapy. This is the effect of radiation you're seeing here. And that's because she also had a parotid metastasis from squamous cell carcinoma. And a radiation oncologist felt that the lower eyelid should be included in the field of radiation. But despite radiation, you can see that her final outcome on the slide right, after the flap is opened and she's received radiation, is still quite good. She has some discoloration of the skin of the lower eyelid, and that's just due to radiation. But overall, a very nice outcome for that large defect from a tarsoconjunctival flap and a full-thickness skin graft. Now, I wanted to mention some of the new drugs. I just, in passing, I know in much of the world this may or may not be available, or if it's available, it may be very expensive and there may be lack of access, but I hope that someday we can have access to these wonderful drugs throughout the world. So this is, I want to show you, this is one of my patients that was treated 3 years ago. He presented with this very massive lesion that is a squamous cell carcinoma. Although we don't know where it started, did it start on the tarsal plate? Did it start on the skin? But you can see the extent of involvement of the orbit with orbital invasion, causing compression of the globe. And this is a very locally advanced, probably I would grade this as a T4 squamous cell carcinoma of the eyelid and periocular region. We elected to give this patient chemotherapy and immunotherapy using an immune checkpoint inhibitor called cemiplimab, which is approved in the United States for squamous cell carcinoma. So a combination of chemotherapy and immunotherapy. After just 2 cycles and 6 weeks of treatment, you can see the massive response. You can see the very dramatic response of this large lesion to chemo and immunotherapy. Then he had surgery with negative margins and reconstruction. So this is a really nice outcome for locally advanced squamous cell carcinoma. So far, I have 2.5 years of follow-up in this patient. He has not had any recurrence. Unfortunately, he has not experienced any metastasis either. So this is a really nice outcome. These drugs, I hope that will become available throughout the world. They are in much of the developed nations, but they are expensive. So gaining access in developing countries is still a challenge. These drugs can also be effective for conjunctival squamous cell carcinomas that are either locally advanced or metastatic. This is the case in this 92-year-old woman that presented with this conjunctival squamous cell carcinoma on the surface of the eye and already with nodal metastasis. So given her advanced age, we did not want to put her through an exenteration and a radical dissection of the neck. So instead, she was treated with pembrolizumab, which is another immune checkpoint inhibitor drug that's available in the United States. And you can see the resolution of both the ocular lesion, completely gone after 2 cycles of pembro, and the resolution of the metastatic lesion. This case was described in ophthalmic plastic and reconstructive surgery, and you can read about it in more detail. But the overall response rate for conjunctival squamous cell carcinomas is not as robust as in skin squamous cell carcinomas, but still we can be optimistic that if the tumor mutation burden is high, we can expect response for patients with conjunctival squamous cell carcinoma, as was the case in this patient. Another really nice indication of drug therapy for squamous cell carcinoma is patients that present with what we call perineural spread. This is a situation where this squamous cell carcinoma of skin gains access to the cranial nerves, most commonly the fifth cranial nerve. In this particular patient shown here, he had multiple skin cancer on his forehead and facial region, and he had likely his squamous cell carcinoma had gained access to his orbital area through the supraorbital nerve. As you can see on this MRI at presentation, first of all, he has total numbness and paresthesia of his forehead. He also has ptosis and limitation of movement on examination. His MRI at baseline shows this large mass around the supraorbital nerve, which is the fifth cranial nerve, and which extends posteriorly towards the superior orbital fissure. So this situation referred to as perineural spread. Historically, we only had high-dose radiation therapy to offer to such patients. Now, high-dose radiation therapy in this situation, where the cornea and the eye cannot be spared because radiation is delivered with targeting the skull base, is also associated with a lot of ocular toxicity and vision loss, and eventually the possibility of a painful eye. But instead, this patient was treated with cemiplimab. Again, this is a immune checkpoint inhibitor. It's a PD-1 inhibitor that is approved in the United States for treatment of squamous cell carcinoma. And you can see his progress over time. After 4 months of treatment, this is an intravenous injection that's given typically every 3 weeks. You can see resolution of this mass over time. The mass has gone away. At 4 months, you can also see his clinical examination is much improved. His ptosis is resolved, his paresthesias and numbness has improved. You can also see that, interestingly, all of his skin cancers, all of his sun-exposed and sun-damaged skin cancer is also resolved in response to this drug. And of course, treatment have continued for 10 months. In this situation, immune checkpoint inhibitor treatment needs to continue for at least a year or two. And this is a very sort of recent advance, and we still need to continue to observe such patients because it's early days for these types of observations, but it's really exciting for patients like this. I'm going to move on to what I consider the third most common cancer that we encounter in the United States. But important to note that in large parts of the world, very highly populated parts of the world, such as Asia, China, India, Japan, sebaceous carcinoma is considered the most frequently encountered cancer of the periocular region, of the eyelid area. So an important entity and well familiar to us, but it's still a rare condition in the United States. This is a cancer of the oil glands, of the sebaceous glands of skin. Therefore, we, in fact, see it often in the sebaceous glands of the eyelid. So the meibomian glands of the eyelid, which are more abundant in the upper eyelid, can get sebaceous carcinoma. And this is why, in fact, we see this cancer more frequently in the upper eyelid. But of course, it can happen in the lower eyelid. It can happen in the caruncle. It can happen just on the conjunctival surface or just on the skin. So any place that you have sebaceous glands, you can get sebaceous carcinoma. Another name for this is meibomian gland carcinoma or meibomian carcinoma. But for the skin at large, it's referred to as sebaceous carcinoma. This condition can be delayed or misdiagnosed, especially when it's presenting in its diffuse format. You know, like this one in this patient in the bottom slide. This is not a distinct lesion, but it can just look like diffuse blepharitis. So unlike the two other patients' lesions here in the upper eyelid, this mass lesion, or in the lower eyelid, this area of focal involvement, here we see a diffuse level of involvement. So these are the ones that are often delayed diagnosed because it can be mistaken for a case of blepharitis, and without a biopsy, it's difficult to make this diagnosis. So it's really important to have a high index of suspicion. If there are areas that, if a patient has just a focal area of blepharitis appearing as blepharitis or a chalazion, and as long as and when it does not respond to conservative measures, it really needs to be biopsied to rule out sebaceous carcinoma. And historically, we used to talk about oil red O as being the stain that's necessary to make this diagnosis. But there are, and oil red O, of course, only can be used on fresh tissue. But more recently, we have access to fat stains that are also diagnostic on permanent tissue, on paraffin embedded sections. So the adipofyllin, for example, can be used on paraffin-embedded tissue. So any biopsy that you do, as long as it's formalin fixed and as long as there's access to adipofyllin, it can still be diagnostic for sebaceous carcinoma. And for pathologists that are familiar with this cancer, just the morphology, the shape of the cells can be, the foamy cells, can be diagnostic. And so as long as they have a high index of suspicion, they would make the correct diagnosis with a biopsy. So a biopsy is necessary to make the diagnosis. These are other examples of sebaceous carcinoma. This one, of course, no one would mistake this as being a sty or chalazion or hordeolum. This is a aggressive process that has grown over time. But ironically, in a situation like this, because it's exophytic and is sort of growing outwards, these are very amenable to surgery. And we talk about doing map biopsies for sebaceous carcinoma, and it's really appropriate for cases that are more diffuse like this, and we might have some areas of injection of conjunctiva or neovascularization of the cornea, and therefore the idea of doing map biopsies to rule out intraepithelial pagetoid spread of this cancer, which can occur. And in that situation, sometimes topical chemotherapy using mitomycin C drops might be appropriate. But otherwise, this cancer is treated surgically. Because it occurs more frequently in the upper eyelid, we can talk a little bit about upper eyelid surgery. Similar to lower eyelid defects, for relatively small upper eyelid defects, these are closed primarily using the same principles as I showed previously by first repairing the tarsal plate. This is the tarsal plate right here and right here, by first closing the tarsal plate and then closing the skin and muscle layer with silk sutures. But for larger defects of the upper eyelid, sometimes eyelid sharing procedures such as Cutler beard flap are appropriate, as shown here. This is basically a through-and-through cut in the lower eyelid is made after leaving about 4 millimeter margin in the lower eyelid. And then the conjunctival flap is dissected from the lower eyelid and brought up into the defect and sutured to the remaining conjunctiva on the upper eyelid defect. And then usually some type of sandwich graft is done. This is alloderm because we have it available off the shelf. You can also use banked sclera, or you can use nothing. The original technique did not use a sandwich graft. And then skin is brought under this bridge and sutured on top of the conjunctiva and the sandwich graft. So it's a complex flap, but it is good for very large defect. And we can see some examples here. You know, this is an entire upper eyelid has sebaceous carcinoma. So this is the defect we ended up with in this lady. And this is a Cutler beard flap in position, sutured in. Even larger defects, in this case, is a sebaceous carcinoma with nodal metastasis, can be repaired if we can save the eye. We can avoid an exenteration. For larger defects, you may need an exenteration. So overall, I think I want to just briefly mention that for sebaceous carcinoma and many of the more aggressive cancers of the eyelid, we do need to pay attention to the regional lymph nodes. We recently published a study of 138 patients of sebaceous carcinoma, and overall, there were 30 or 22% of patients that had nodal metastasis. And important to note that about half of them were diagnosed during the follow-up period. So they did not have nodal metastasis at presentation, but they developed it over time. So it's really important to follow these patients for up to 5 years and pay some attention to the regional lymph nodes, whether it's palpation, ultrasound, CT scans. That's really important. So I'm going to move right along. We have just a few more minutes left, well, 10 minutes left. I'm going to cover some other entities that happen in the eyelid area. They may be less common, but important to at least know about. One of those is Merkel cell cancer. Merkel cell cancer, again, it's a skin cancer, but it can happen in the eyelid area. It is a rapidly growing lesion. So it may start very small, but then it can like really rapidly grow to the sizes that you see here. Typically, it is violaceous. It's kind of purplish in color, so that might help in terms of diagnosis. And this cancer has a very high risk of lymph node metastasis. We say close to 30-50% of the times with the larger lesions, you can have nodal metastasis, so much so that some practitioners would empirically radiate the regional lymph nodes when dealing with a Merkel cell cancer. The treatment for Merkel cell cancer is surgery, but it is also sensitive to radiation. So if surgical treatment for the upper eyelid, for a large reconstruction of the upper eyelid is not available, radiation could be an option, but it does have side effects for the eye. So I personally prefer surgery. And then, of course, reconstruction. We just talked about a Cutler beard flap. This is a patient that has been treated with a Cutler beard flap. You can see the recent incision here. This is early post-op. She still has sutures in place. But this is a reasonable outcome after a Cutler beard flap. There may be still some, because of the total loss of the upper eyelid, there is also tear film insufficiency and dry eye issues that they may have to take care of for the rest of their life, but still it's a reasonable outcome from a aesthetic standpoint. Some patients after Cutler beard flap may require a bandage contact lens to remain fully comfortable because there is, again, total loss of meibomian glands. So there is a need for some type of bandage lens or continued lubrication for the cornea. But overall, the aesthetic appearance is quite nice. Again, not to get too detailed about nodal metastasis, but important to pay attention to regional lymph nodes when it comes to Merkel cell cancer. And again, recent advances in this area is the availability of immune checkpoint inhibitors. The same drugs that I showed you that have efficacy for squamous cell cancer also work for Merkel cell cancer, and they can lead to really nice outcomes for our patients, both in terms of tumor shrinkage. For large upper eyelid defects, you can use immune checkpoint inhibitors to shrink the Merkel cell cancer and then do surgery. And also for cases where there is already lymph node metastasis, it can be quite effective. I'm going to say a few words about eyelid melanomas. These are a little more frequently encountered in Western hemispheres. They may be less commonly seen in Asia or in Africa, but still potentially aggressive cancer and potentially life-threatening, so it's worth mentioning at least. These are treated surgically. We treat melanomas with wide local excision. Frozen section is not effective for melanoma. It's questionable because it can be very unreliable. So we do wide excisions with just a safety margin. And I typically do delayed reconstruction only after we have confirmation that the margins are clear. And of course, the same techniques are used for reconstruction. We've already mentioned them. This patient happens to have a melanoma around the punctum in the lower eyelid. She's had a wide excision here with loss of the canaliculus, and then she's had a Hughes flap in place. And then after the Hughes flap is open, she looks great. She has a great functional lower eyelid. She's missing the canaliculus, but this in most cases is not an issue. We can later consider some type of CDCR if she's really bothered by excessive tearing, but usually I don't do that primarily, and many patients don't require that. Here's happens to be an amelanotic melanoma nodule. This is a melanoma. We've marked the safety margins. This is the wide excision, the defect, and then it's repaired with a Hughes flap. This happens to be a melanoma in the tarsal plate in the upper eyelid. So don't forget about that. Always upper eyelid eversion is really, really important when you examine patients for adnexal cancers. And she's been repaired with a partial Cutler beard. So it's just a defect in the medial half of the eyelid that's been repaired, but a nice outcome for her. And another melanoma happens to be in the lower eyelid. I'm just showing you the full spectrum of melanomas. We do pay attention to regional lymph nodes. This patient happened to have a sentinel lymph node biopsy that was positive, but you can also do ultrasounds or CT scans to rule out lymph node metastasis. And of course, we have immune checkpoint inhibitors for treatment of melanoma. In fact, immune checkpoint inhibitors that I've now mentioned it for squamous cell cancer, for Merkel cell cancer, and now for melanomas, they were originally discovered for the treatment of cutaneous melanoma. So they are available. This patient happens to present with a melanoma of the lower eyelid, but already has lymph node metastasis at the time of presentation. So he was given immune checkpoint inhibitors. This particular drug is called relatlimab. There are quite a number of drugs that are now FDA approved in the United States in the class of immune checkpoint inhibitors. He was treated with this drug, and lo and behold, his melanoma shrank in the lower eyelid, and his lymph node metastasis also responded. So then he had surgery around this lesion, and he had no melanoma remaining after drug therapy, and his lymph node metastasis had also resolved. So just quickly mentioning that surgery can also be done outside of the lower immediate eyelid area, and can be effective, and you can do local flaps to close them. Small flaps to close them are quite handy. Or this glabellar flap that I mentioned to you, this can be just using the redundant skin that most people have in the glabellar area. And this is the outcome here. Initially, there's some scarring here, and the patient may get a little bit of approximation of the brow, but at least in women, this can be handled with waxing or shaving, and it's really not a big issue. And over time, these scars also blend in nicely. And then we can have more complex lesions, more complex defects. This is a basal cell cancer. You can see that it involves the upper eyelid, the lower eyelid, and the medial canthus. So the defect might look like this after we achieve negative margins. But in this case, you have to pay attention to all the areas that have tissue missing. There's both the lower eyelid, the upper eyelid, as well as the medial canthus. So he's been treated with a partial Hughes flap, harvested from the remaining upper eyelid. And then the upper eyelid is advanced medially and attached to the bone here. Of course, his canaliculi are all gone, so we expect some excessive tearing. And then he's had a glabellar flap for the remainder of the defect. So initially, after surgery, he may look like this. There is a little bit of ptosis, and there's some pulling here, but then that can be addressed secondarily with a second surgery to correct it. So this is his final outcome. And this particular patient is not bothered by excessive tearing because of his age and because of lack of production of tears. So this is a good case to remember that if faced with a defect like this, you just have to think systematically about all the structures that are involved and address each of them accordingly. So I'm coming to the close of the 40 minutes, and I want to summarize what we talked about in broad strokes, and then we can entertain some questions. So important to note that malignant tumors of the eyelid are quite varied in their presentations and in terms of the different types. Depending on where you live in the world, there could be different frequency of different types, but the overwhelming majority of them can be addressed with surgery. I would think particularly in environments where access to the newer drugs is limited, I think surgery still plays a very important role, and familiarity with the reconstructive options is really important. And I think as complex as they may seem initially, I think with some experience and some perhaps focused training and then experience, they become quite routine and they're quite reliable. And we can really do surgery and do eye-sparing surgery and reconstructive procedures in the majority of cases, thankfully, and have a reasonable outcome. But of course, non-surgical treatments are available targeted treatments, immune checkpoint inhibitors, have quite a bit of efficacy for locally advanced basal cell cancer, melanoma, Merkel cell cancer, and squamous cell cancer. So really the overwhelming majority of cancers that occur in the periocular region can now be targeted or treated with immune checkpoint inhibitors. So the importance of global efforts to bring access for these newer drugs to large parts of the world. And I think we need to have a little bit outside of box thinking in this area to encourage our pharmaceutical companies to actually provide these drugs in developing nations. And so these drugs can be used prior to surgery or after surgery, and in cases of perineural spread can be used instead of radiation. And I just wanted to talk, not forget about the risk of metastasis in patients who have the more aggressive varieties. This doesn't necessarily apply to basal cell cancer because basal cell cancer very rarely metastasizes. I didn't even mention it in relation to that. But it would be applicable to sebaceous carcinoma, melanoma, Merkel cell cancer, and for larger squamous cell carcinomas. So some attention to regional lymph nodes, whether it's with palpation. Palpation, of course, is not as good as ultrasound or CT scans. But we need to either, as ophthalmologists, do that ourselves, order those tests ourselves, or refer the patient to medical oncology so that the regional lymph nodes can be evaluated properly and then continue over time with surveillance of both the eye area, but also the regional lymph nodes. The question is, I would like to know something. After undergoing eyelid tumor surgery, can the eyelashes grow back? Or what is the chance of eyelashes growing back? Okay, the answer is no. Unfortunately, the eyelashes do not grow back because we are bringing tissue from upper eyelid and there's really no lash follicles in the tissue that we brought down. So for larger defects where you're doing those eyelid sharing procedures that I described, there will be no eyelashes. If you're closing primarily, of course, the lashes are still there. Now, some patients will get aberrant hair growth, right? So when you do a skin graft on top of a Hughes flap, for example, that skin graft has some hair. That is not an eyelash, but you may get those hairs in the skin graft that sometimes might touch the cornea. So if you see a hair against the cornea, that is really the hair on the skin graft. It's not an eyelash. So I hope that addresses that question. Next question is, what can be an alternative to the Hughes flap for children? Okay, good question. I think in children, one alternative honestly can be just granulation. It really depends on the size of the defect. So in some parts of the world, lower eyelid defects are allowed to just granulate. The outcome is not as good, but the cornea can still do reasonably well. So if you can support the cornea with lubrication, with patching, with things like that, maybe with temporary tarsorrhaphies, it's possible that a lower eyelid defect can granulate in appropriately. But as we talk about this is not ideal because even a tarsorrhaphy can be amblyogenic in a child, so that's really not that great. Other surgical alternatives might be using the periosteal flap. As I mentioned, you can harvest quite a bit of, you can harvest at least 15 millimeters of lateral orbital periosteum as your posterior lamella. That can be a nice alternative. Again, it really depends on the size of the defect. One can use a tarsoconjunctival graft harvested from the upper eyelid as a replacement for the central lower eyelid defect. So that can be done. It's still, you have to go into the upper eyelid and harvest the graft. Instead of keeping it attached to the upper eyelid, you can just use it as a graft in the lower eyelid. These are some possibilities when dealing with a large central defect in a child. Let's see. Next question is, what treatment regimen would you recommend for pigmented squamous cell carcinoma of the conjunctiva that affects both the palpebral and bulbar conjunctiva? Would you do chemo or do an exenteration? Okay, good question. Well, whether it's pigmented or not, the treatment is the same. The treatment is for the squamous cell carcinoma. Now, if we're dealing with a conjunctival squamous cell carcinoma that is large, it involves the bulbar conjunctiva and the palpebral and tarsal conjunctiva. It's challenging when treated with surgery alone. Why? Because we're going to have raw surfaces on the surface of the eye as well as on the eyelid. So even if you attempt to reconstruct it with amniotic membrane grafts or, let's say, mucous membrane grafts, there's still going to be a lot of adhesions between the globe and the reconstructed eyelid. So it is a challenge. It's not ideal. The outcomes are not going to be great. But if you have access to chemotherapy and immunotherapy, now I showed that really dramatic response to chemo and immunotherapy. So it wasn't just chemotherapy. You know, if you use chemotherapy alone, you may not get that type of dramatic response. So if you have access to systemic chemotherapy, meaning intravenous chemotherapy plus immune checkpoint inhibitor therapy, pembrolizumab, cemiplimab, you may try. It doesn't work in every case, but it might work in a given patient in shrinking the lesion. You might use topical chemotherapy using 5-fluorouracil, for example, and see if the lesion will shrink. That's another option. And I think exenteration can be used as a last resort. I mean, if the patient doesn't respond, or if you attempt eye-sparing approaches, but if there's recurrence or there is lots of adhesions between the reconstructed lower eyelid and the bulbar conjunctival surface, then you may eventually end up with an exenteration. So those are challenging cases in any environment. You know, they're challenging cases for me as well, because drugs don't always work, and reconstructing the ocular surface and the eyelid at the same time leads to a lot of adhesions. So it's really not an easy situation. Okay, I hope I addressed that one adequately. Now, next question, what treatment regimen would you recommend? Oh, I think we did, that's, I see. Would you recommend for squamous of cancer of conjunctiva? I think that's a repeat. Possible affectation of the lacrimal gland, would you do chemo or do an exam? Okay, so I think we're talking about a squamous cell carcinoma that also extends into the orbit, into the lacrimal gland. Yes, similar answer, really, to the previous one. If you have access to chemo and immunotherapy, you could try to see if you can get resolution of the lesion and then do something short of an exenteration. But if the patient doesn't respond, or if you don't have access to those drugs, then unfortunately you are limited to doing an exenteration. So similar to the previous question, I mean, it's basically a situation of a locally advanced squamous cell carcinoma. And if you don't have access to drugs that are effective, or if the patient does not respond to the drugs that are available, then exenteration, unfortunately, is the only thing we can offer. Please expand on Mohs surgery. What is the setup in the operating theater to facilitate frozen section? Is a pathologist involved? Okay, two different things. Mohs surgery. Mohs is the surgical treatment. It's named after Dr. Frederick Mohs. Dr. Frederick Mohs was a dermatologic surgeon in the 20th century. So when we say specifically Mohs surgery, we're talking about the surgical excision being done by a Mohs dermatologic surgeon. That's usually done under local anesthesia. It's done by the Mohs surgeon. And then once the surgical margins are clear of cancer, then the patient is referred to the ophthalmic plastic surgeon for reconstruction. That's the typical Mohs surgery done in, let's say, the United States and some parts of Europe. But if you don't have access to a Mohs surgeon, another alternative is to do the surgery in the operating room with frozen section control of the margins. That would require that you have access to a pathologist, ideally a dermatopathologist or a pathologist that's familiar with these cancers. And at the time of surgical excision, you give dedicated margins around the lesion, around the major obvious cancer. You do dedicated margins and do frozen section control of the margins. So that's not Mohs surgery, but it's done in the operating room with frozen section control of the margins. But it's using a Mohs type technique in that you are evaluating all the dedicated margins, and only after they are all clear, you then do the reconstruction. I hope that answers that question. What would be your approach for sebaceous carcinoma with orbital extension? Would you outright exenterate, or is there a role for chemo or radiotherapy? So sebaceous carcinoma is an interesting cancer. I intentionally did not mention chemotherapy, but I could. I mean, I think there are some studies. They are small in terms of numbers, so we don't have hundreds and thousands of cases, but there are studies specifically from India that showed that there is response, not in every patient, but something like 40 to 50% of the patients with locally advanced sebaceous carcinoma with orbital invasion or with metastasis. You can get some response to chemotherapy with shrinkage of tumor and therefore try to avoid an exenteration. So that's with standard chemotherapy. So that's using platinum-based chemotherapy and 5-FU. That's the data from in India. I have tried that in our patients in the United States, maybe with a slightly different chemotherapy cocktail, avoiding 5-FU if we can because of toxicity. But you can have some responders and you can have tumor shrinkage. As with any type of neoadjuvant treatment, it's really important to follow the patient because some of those patients may recur and you may need to eventually do an exenteration. Radiation therapy, giving it before surgery really does not make sense. If you're using it after surgery, it's going to have some toxicity to the eye. So as long as we pay attention to that and prepare the patient for that, it may still lead to an uncomfortable eye if it's used with high-dose radiation therapy. So I think as an estimation, still about 10% of our patients with sebaceous carcinoma end up with an exenteration because these various different methods may not work. Immune checkpoint inhibitors, which are the newer drugs, work in some patients with sebaceous carcinoma, but not as high a percentage as with squamous cell carcinoma, because sebaceous carcinoma has a relatively low tumor mutation burden when it comes to that, not as robust a response as with squamous cell carcinoma. Okay, let's see. How do you choose the proper immune therapy for each case and type of malignancy? Okay, that is really not, it's a general term. So the drugs that I mentioned are not specific to a particular cancer. They will work for the cancers that I mentioned. They will not work for every patient. No drug works for every patient. But for squamous cell carcinomas, for cutaneous melanomas, for some cases of conjunctival melanoma and conjunctival squamous cell carcinoma, and for Merkel cell cancer, you can expect a high response rate with immune checkpoint inhibitors, specifically PD-1 inhibitors. And I have personally published papers on this. You can look them up. The overall response rate is at least 50% for the cancers that I mentioned. It has to do with tumor mutation burden. So cancers that have a lot of mutational burden, specifically, let's say, ultraviolet exposure type of cancers, they are expected to have a higher response rate with immune checkpoint inhibitors. But the specific type of immune checkpoint inhibitor drug, if that's what you're asking, really depends on availability and FDA approval. But they all work the same way. All PD-1 inhibitors have a similar mechanism. So if you have access to any PD-1 inhibitor for the diseases that I mentioned, it would be worth a try. Okay. Are there any emerging technologies such as intraoperative imaging, AI-assisted diagnostic, or robotic tools being integrated into malignancy surgery. Yeah, there are. In every meeting we go to, we see one abstract on a few cases or in an animal model on these kinds of things. I would say it's not being used in our day-to-day surgical cases, still not being used in the United States. So it's a good area for exploration and for discovery, but I would say that we're not seeing it used in real time, in real life currently. Okay, what is the concentration of mitomycin C for sebaceous carcinoma with pagetoid spread, and how do you give it? Sure, this is a bit operator dependent. My preference is 0.02%, simply because there's really no studies to suggest that higher concentrations are any more effective. So I use 0.02% mitomycin C. I use it 4 times a day. And I give it with breaks, which means I tend to use it for 4 days on, 10 days off. So I use 2-week cycles of 4 times a day, 4 days on, 10 days off. 4 days on, 10 days off. Then I repeat it for 4 cycles. So let me repeat that. 0.02% given 4 times a day for 4 days. Then you take 10 days off. Then you give it again for 4 days and you take 10 days off and you repeat it again if the patient is tolerating it. Why this method over time I've developed over close to 30 years of practice is because after 4 days is when they start to get the irritation of the cornea and the ocular surface. So it's good to take a break after 4 days. And why repeat it for 4 cycles? Because, well, we want to see resolution of the pagetoid spread as much as possible. But let me just say that I view topical chemotherapy with mitomycin C simply as a temporizing measure, meaning it's just palliative, it's buying time. Most patients eventually will get a recurrence if you're only using topical mitomycin C. So it's really only good for buying time. It's only good for very limited areas of involvement. It's only good for when you've already done very good clear margin surgery, but you might have had some areas of pagetoid spread that you removed, or you have nearby, or you have one positive margin and you're just trying to mitigate that. If it's widespread pagetoid involvement, I'm not terribly optimistic that in the long run you're going to achieve good local control. It's certainly not good for patients who are not reliable for follow-up. In the very elderly population, where you really are just trying to buy time, or maybe someone has one eye that's seeing, you're trying to buy a little bit of time, you can allow them to have as much vision as possible for as long as possible. It's okay, but I don't view it as curative. Okay, what about, we just have a couple minutes because I'm sorry I have to go in a few minutes, but we'll cover as much as we can. And then please email me. I'm going to type my email into the chat box, and you can email me with any additional questions, but I can cover at least one more. What about large defects in pediatric patients, whether it's traumatic or after malignancy? What's the recommended procedure to reconstruct the defect? So we kind of covered this for the lower eyelid. For the upper eyelid, similarly, I mean, I think the only difference in pediatric population is the concern for amblyopia, right? So if you have a child that's 8 years or older, I don't think I would be too worried about amblyopia. But if you're dealing with a defect in a young child under age 8, then we just don't want to have these eyelid sharing procedures for a long. You may want to consider opening the flaps earlier than, let's say, 6 weeks, which is my standard for a Hughes flap, or you may use alternative ways of reconstruction, as we talked about, maybe granulation in the lower eyelid. In the upper eyelid, granulation does not work that because the cornea is so exposed. You may use things like tarsoconjunctival grafts instead of flaps. You may try to harvest periosteal flaps, recruit periosteal flaps. from the lateral orbit, at least for 15 millimeters of posterior lamella. So using tricks to not have the eye closed for a long period of time. So really, that's the only challenge in pediatric population. You don't want to have the eye without any visual stimuli for longer than a few days, ideally. But you do your best, right? I mean, if you have a massive defect of the upper eyelid, you have to reconstruct it, or the eye will go, you'll have a ruptured globe from corneal puncture. So you just have to weigh the which is the worst outcome. Okay. Yeah, interferon. I'm going to cover the interferon. Topical interferon is not available in the United States anymore. If it's available to you in your local area, it works for conjunctival squamous cell carcinomas. So similar to topical chemotherapy, I think interferon drops for conjunctival squamous cell carcinoma can be used if it's available to you. It's no longer available in the United States. There's no magic number of millimeters for clear margins for carcinomas. You just have to use frozen section as a reliable method. And thank you for your attention. I think I covered most of them. Let me type let's see, how can I type into the QA? I'd like to type, let me see if I can. I'm going to type an answer to all of you. This is my work email address. If you want to communicate with me, I would love to learn about your local challenges and your local environments, and try to problem solve in your local geography and the challenges that I know you all face from parts of the world that you have to work with limited resources, but still I'm sure you accomplish wonderful results. And I think surgery can be very powerful when you don't have access to drugs and radiation therapy. So I think getting good surgical training, in my opinion, is very important in areas where we don't have access to the latest technology and the latest drugs, because still surgery is in your hands. The power is in your hands and in your knowledge and in your skill set and experience. So I think surgery is still really a powerful tool in many parts of the world.